The only time I can table motions is during this committee time, so I hate to do it, but I have to.
In the vernacular, give me a break. That's absolutely untrue. This is foolishness. We have a system falling apart, 7 million Canadians without access to primary care, that both of these individuals who bring forward a motion and an amendment to a motion had the opportunity to address over 9 years and think they have to do it now. On behalf of Canadians, this is wrong. In that spirit, Chair, I would move to adjourn debate so we can get back to the important matter at hand that we have.
This guy's garage. Like and subscribe.
3. The committee is resuming its study of the opioid epidemic and toxic drug crisis in Canada. I'd like to welcome our panel of witnesses. We have with us today, appearing as an individual, Dr. Patricia Conrad, a clinical psychologist and professor of psychiatry and addiction at le Centre Hospitalier Universitaire Sainte-Justine, Université de Montréal. Elle est ici par vidéoconférence.
She's here by video conference.
Judson also appearing virtually, and Gregory Sword, who was with us in the room. Representing the Canadian Mental Health Association, Margaret Eaton, National Chief Executive Officer online, and Sarah Cannell, National Director, Public Policy. Thank you all for taking the time to be with us today. So starting with the Conservatives, Ms. Goodridge for 6 minutes, please.
Thank you, Mr. Chair, and I want to thank all the witnesses for their testimony, and specifically to Gregory Sword for sharing about your daughter's circumstance. I really appreciate that. I'm going to start my questions to Dr. Judson. In your opening statement, you stated that both Health Canada and the College of Physicians and Surgeons of Ontario have seemingly abdicated all responsibility for oversight. I was wondering if you could expand on that.
First started prescribing methadone. I had to get approval from Health Canada. I had to have a special exemption to be able to prescribe methadone. It was contingent on having taken a course in the prescribing of methadone, which outlined its neurochemistry and the effect on the pharmacokinetics of methadone. I had to meet special requirements before the College of Physicians and Surgeons that I was in good standing to be able to prescribe opioids. And so those two authorities, the College and Health Canada, effectively screened me out as being someone who was going to be prescribing methadone for legitimate reasons, and the likelihood of over-prescribing, inappropriate prescribing was minimal. That seems to be not the case, just because the number of patients who are experiencing opioid misuse renders it far too difficult for them, for physicians. There are so many physicians treating that patient population that it's really impossible to keep controls over things. It would just consume far too much time. I presume. I can't say more than that.
Thank you. Could you, in your professional opinion, share what is the correlation between the availability of substances and the harms they cause?
Well, if you think not just of opioids, but recognize that all substance misuse is the problem. It doesn't matter what you use. It's the fact that an individual uses a substance that really defines what addiction is. And as long ago as the early 70s, soon after I opened up in practice, I was impressed by a research paper that had been published by a sociologist at the University of Western Ontario. His conclusion was that the more available alcohol is, the more alcohol is consumed. The more alcohol than is consumed, the more problems occur as a result. And that has recently been corroborated by a study conducted actually in Ontario, but published in the journal entitled Addiction, which is published in the UK, which looked at opioid use. And the conclusions were that the more opioids that are prescribed, the more opioids become available to all people for legitimate and illicit reasons, and the more problems occur as a result, including increased health issues and increased visits to emergency rooms. So those two reports, spanning a 50-year history space, indicate the more substances are available, the more problems there are going to be, and that's what we're witnessing as a result of these safe supply clinics, which are putting an abundant amount of opioids onto the street. And if they were better regulated, these clinics, then that would probably rein in the amount of opioids that are finding their way onto the streets.
Thank you. Dr. Conrad, I see you shaking your head, and could you perhaps expand and share your thoughts on that subject as well?
My understanding of the literature is very similar, so I concur with all of those comments. And it also puts people at risk. So the more substance use and in the adult population, the greater risk for a youth population, the more the liberal attitudes about substance use, the more young people are likely to use and at younger ages. And there's even studies demonstrating that proximity to alcohol outlets, for example, will influence young people's rates of substance use, alcohol use, for example. And I'll reiterate how concerned I am about the fact that opioid use amongst young people is rising. And what that means is that Canada will continue to have a very significant problem for decades to come.
I appreciate that. Greg, so how easy was it for your daughter to get access to these potent dilaudid pills?
One message on either Snapchat or Instagram, and she would have someone delivering her whatever she wanted within 5 minutes. She could get dillies, cocaine, acid, alcohol, whatever she wanted. Even after she died, they were still messaging her cell phone. My friend had access to her Snapchat account, and they were still asking if she'd need any dillies.
Camilla's friends have said that dillies were widely available at their school. Can you expand on this? It terrifies me as a parent that high potent opioids are available in schools.
Most of the kids there would get the supply from someone who would go into the Vancouver East side, and they would be able to pick up a bunch of pills and bring them back into the smaller communities where I lived. And before my daughter died, there was 2 other girls in the same area who had died of the same thing with no mention of it. I only found out from other parents. It is so easy for these kids to get their hands on it because we don't monitor it in BC. We just hand out the pills, hope that the addicts will take them and not sell them for the drugs that they want. So they give them to the kids or to the gangs, and they come back out to the smaller communities.
Thank you, Mr. Sword. Madame Briere.
What can push someone to use, and what these prevention measures could look like? And if you could talk to us about prevention measures that you are currently working on. Do you mind if I respond in English?
Yep. So thank you very much. You've clearly done your research, and I appreciate that. So absolutely, there are a number of evidence-based prevention programs that should be widely available to all young people. There are only 3,400 high schools in the country. That's not an enormous task. They are under-resourced and do require dedicated resources in order to support these programs, because they are not just a poster in a hallway or a lecture by someone who has had an experience with substance use. These are psychological interventions or multi-year programs that involve building skills in families and in young people that help them manage stress, confidently resist peer pressure to use. So giving young people tools on how to say no really does work. Counteracting some of the social norms that come from social media, and my research has demonstrated that social media is promoting problematic substance use norms, as well as norms that come from other media and families and society generally. But then I want to talk to you about prescription drug misuse, because prescription drug misuse appears to be particularly linked to risk for other mental disorders. And what we now know from decades of research on psychopathology and neurodevelopment is that there are a number of risk factors for early onset mental health problems. And there are psychological traits that are very good markers of who is likely to develop difficulties with anxiety, depression, impulsivity, and ADHD, as Mr. Sorg described, and other thrill-seeking behaviors. And though young people can report on those traits very easily, and how they report on individual differences such as impulsivity and thrill-seeking will predict who is likely to misuse a substance, what substance they are most likely to misuse, what prescription substance they're most likely to misuse, and what kind of mental health difficulties they're likely to experience in relation to their substance use. And my work has demonstrated over and over again, and these are large randomized trials that have been conducted in the UK, in Australia, and in Canada, and in Europe, involving thousands of young people, that you can deliver cognitive behavioral mental health interventions early on, 7th, 8th, and 9th grade. And when they're delivered in high fidelity by a trained mental health professional, you can delay the onset of substance use in young people. You can prevent young people from developing a substance use disorder. And I believe we haven't yet demonstrated this scientifically. That is how you're going to begin to start to address this problem and reduce the burden on the acute substance use and mental health services. You have to help young people delay the onset of use and stop new users from taking up opioid use, which is what is happening right now and increasing every year for the past almost 10 years.
Que vous avez développé Preventure.
You developed Preventure. Yes.
Est-ce que vous voulez que
Would you like me to talk about that program?
The Preventure program, and I have to say, is one program that I was involved in developing, but there are other researchers, for example, Dr. Sherry Stewart at Dalhousie University, who has collaborated with me in this. And this is a program that has just been packaged to be able to train school-based mental health and educational professionals on how to effectively deliver cognitive behavioral interventions preventatively. And so this program has been demonstrated to be effective when it's disseminated broadly in a community. In about a month's time, there will be a large publication that will come out of the American Journal of Psychiatry demonstrating a randomized controlled trial in Montreal, involving 31 high schools in Montreal, in which there is a very significant effect on substance use outcomes over a 5-year period. Other trials in Australia have also demonstrated that the Preventure program is effective in reducing substance use over 7 years of a young person's life trajectory. So the program has been very widely tested. It's mentioned as an evidence-based program in the Surgeon General's report that was published in 2016. So I have a lot of experience doing this work in schools in Canada and around the world. Through that experience, I do see that schools have become more and more burdened. They're less well-resourced to do the work. And as my colleague said, they are overwhelmed. Rates of just staff turnover and burnout are very high. social media, addressing bullying, and this need for testing in schools has overwhelmed psychological resources in schools right now. So that's why my recommendation was it's absolutely necessary that we add to the available resources in schools across the country, 1 or 2 health professionals or prevention professionals across the country in every school would dramatically improve young people's lives and reduce the risk for further addiction and overdoses, in my opinion.
Thank you, Dr. Conrad.
This question is to Dr. Judson. You mentioned in your comments the difference between someone being prescribed a controlled substance and how that medication is closely monitored by their doctor and their pharmacy. Can you explain to those that are watching how this differs from what is now referred to as, I'll say, so-called safe supply that we're seeing in our communities?
Willingly, I'd first like to say that I concur and endorse the comments offered by Dr. Conrad. So we share the same opinions. First off, I would say that it's a misnomer. The very fact that these clinics are called safe supply is an attempt at misinformation, implying that anybody who takes these drugs will be perfectly safe to use them. All they are is just pharmaceutical grade opioid prescriptions. So the recipient knows that the drug has come directly from a pharmaceutical company and it's not been made in a street clandestine laboratory. But the use of such medications is still dangerous, and using the short-acting opioids is just an alternative to patients perhaps using street opioids. But I want to emphasize that the taking of the medication, whether it be methadone or dilaudid prescriptions, is just a small part of for addiction. I always emphasize that when prescribing methadone or Suboxone to a patient, that was an attempt to engage with the patient, establish rapport, and get them steered in the right direction of going to address their psychosocial needs. And the perpetuation of a supply of opioids is in actual fact just perpetuating the addiction. It's not doing anything to change the lifestyle of the individual. That's where most of the resources need to go. And if we're spending a lot of time and money prescribing short-acting opioids, we're in actual fact not really affecting any change.
Thank you. Thank you, Doctor. This is kind of ripped out of the headlines, but I want to get your comments on it. Just yesterday, a police raid at a heavily used harm reduction site in Nanaimo resulted in several criminal charges against 2 people. In summary, one individual was charged with 14 counts of possession for the purpose of trafficking and 8 weapons offenses, and another was charged with 6 possession for the purpose of trafficking counts and 5 weapons offenses. Doctor, based on your extensive experience, does that news surprise you?
No, because crime and addiction sort of somewhat inextricably linked. But I want to emphasize it's not the patients who should be, or the users, those who suffer with substance misuse disorders. They're not the ones who should be targeted. It's the dealers and the suppliers who need to be reined in. And that's why I feel sufficiently strongly that many of the doctors who are prescribing short-acting opioids, I question whether they really understand the harm that they're perpetrating. They're not regulated. If they have inadequate education on the subject, that is just going to contribute to the problem. And I want to emphasize to you that I refer to substance misuse as the 421 condition. Most medical students spend 4 years in their institutions. They, if they are lucky, will get 2 hours of teaching for what is the number 1 cause of morbidity. So if you're graduating doctors who really don't understand addiction, you can see how easy it is for them to overprescribe, inappropriately prescribe. And the same applies to pharmacists. They don't have the training and education which is necessary to curb excessive amounts of opioids ending up on the street. And most of those opioids that seemingly are coming from safe supply are ending up in the hands of the traffickers, the accounts of which you just described, because they're accumulating these supplies because that is their business to promote drug use.
Thank you, Mr. Moore. Dr. Hanley.
A child is in distress, but not asking for help. Are resources in place? Are interventions in place to assist such a child? And what would you amplify to enable that child to be able to be helped? And I'll ask you to keep it as concise as possible because I have many questions.
Thank you very much, Mr. Hanley. Thank you very much, Mr. Hanley. My response would be the short answer is no. We do not have the necessary supports to help children and youth deal with the mounting mental health and substance use health challenges that they are facing and are going to face as they age. The solution is, to echo Dr. Conrad's points, is building in upstream preventative and mental health promotion interventions that meet them along the way and create effective referral pathways into available community-delivered out-of-hospital treatment options, whether that be early psychosis intervention, prevention programs that deal with addiction and substance use health, to name a few. The issue is that everything is behind a paid door or not available or behind long wait lists.
Thank you. Ms. Kennel, do you consider mental health care a part of primary health care?
100%, and I would gauge that it is core to what medical students learn every day. The challenge, though, is that our health system is not equipped to deliver mental health and substance use health care on par with physical health or primary health. With the shortage of access to family physicians and the lack of adequate and robust training that our medical health care professionals receive, the resulting consequence is that people don't know where to go to get help or face long wait times or inadequate solutions when it comes to addressing their mental health concerns.
I want to give a minute to my colleague, Mr. Morris, to be able to ask a question.
Thank you, Brendan. Appreciate it. The situation in my community in Waterloo Region is dire. Over 63 folks have died from preventable deaths this year. We haven't seen organizations get renewed funding from the Substance Use and Addictions program as of yet. And we also have a premier who's looking to close safe consumption sites that are saving lives. I guess my question for the CMHA, I really appreciate you've worked with Thresholds to launch an integrated crisis center for mental health in our community. Thank you for that. In your testimony, you talked about having Health Canada launch a new task force for a national strategy to address this crisis. In the time I have left, maybe 30 seconds or so, can you share just a few key points of what you'd want to see in that if we're to listen to the experts and not the partisanship?
Thank you very much, Mr. Morris, for the question. And I just want to really reiterate that the view of the Canadian Mental Health Association is to provide comprehensive wraparound care that spans upstream interventions to help prevent the onset of crisis into more acute services, and then really support people into their path towards recovery. And I would be remiss if I didn't take a moment to really echo support for that wraparound long-term support, which is the social determinants of health. As my colleague Margaret mentioned, unless we have adequate housing, unless we have income supports, we will be facing a revolving door of a crisis. And so our recommendation to Health Canada and the federal government writ large is to develop a comprehensive and integrated plan which scopes out what existing programs are available for community providers like CMHA and others to do that life-saving work on the ground, to fill the gap of what's being provided through the acute care system, and then assess where are there additional gaps. And perhaps it's prevention in school-based prevention programs. Perhaps it is more investments in the social determinants. But we need to take a whole of society, a whole of government view of what the federal jurisdictional responsibility is, and that begins with a plan.
Thank you, Ms. Kendall. Thank you, Mr. Morris.
I need to move some motions right now. First motion was put on notice that the committee instruct the chair to write to the Auditor General of Canada to recommend that a performance audit examining the federal government's response to the opioid and toxic drug crisis in Canada, including but not limited to its management of programs identified in the Canadian Drugs and Substances Strategy, be initiated and conducted on a priority basis. I'd like to speak to the motion briefly.
The motion is in order as it relates to the subject matter at hand, so the debate is on the motion. Thank you, Mr. Johns. Dr. Ellis, please.
Thanks very much, Chair. You know, the biggest problem that I would have with this motion, of course, is there's ample opportunity at other times to discuss extending the study on opioids, which to me this directly relates to it. And I think that when we have witnesses here for our friend from the NDP to be needing to bring this forward now is a little ridiculous, when, as I said, there was more than ample opportunity to bring this up at many other occasions. And I'm not sure why this grandstanding is ongoing at the current time.
Mr. Johns?
It's not grandstanding. I'm trying to get this motion moved so that we can write to the Auditor General. And I just put it on notice last week. So this is just timely, trying to get it moving so we can write the Auditor General. I don't think there should be any objection to this.
Any further debate on the motion? Seeing none, are we ready for the question? All those in favor of the motion presented by Mr. Johns, please raise your hand. All those opposed? The motion is adopted. Next, Mr. Steinley, please, for 5 minutes.
Thank you very much. And this is for Dr. Conrad. We've done the so-called safe supply experiment about 9 years now. And I was wondering, before and after, do you have the numbers of overdose deaths before safe supply started for approximately 10 years, and for the 9 years after safe supply has been introduced into the Canadian public by this NDP Liberal government? Has there been numbers, and could you say and extrapolate some information between how many more overdoses we've had in our country before and after this, what they call safe supply, which I don't agree with, experiment?
I'm afraid I can't directly answer your question. I don't know if the data that exists right now could even answer that question. There are a number of different factors that have changed over the past decade and 2 decades that have contributed to the, where we are at right now. I do want to just clarify one thing. So this notion of safe supply is kind of a mixed bag of treatments, services, and possibilities. And I know that there's some researchers from the CRISM network who intend on producing some material that might be helpful to the Canadian government and communities across the country to better just unpack what is meant by safe supply, what practices are safe, and what might actually have unintended consequences for the broader population. So we need a lot more work and clarity around some of these practices.
Yeah, I appreciate that very much. And Mr. Sword, thank you for being here. I had a conversation with a constituent, and I came into my office, and his son had overdosed as well, and his conversation was very similar, just the ease with which his son, and he overdosed, and this gentleman's grandson was sitting there when his father overdosed, and he was sitting in front of the TV when his grandfather came and found his son dead. And he said the biggest thing he could not do is stop with the ease which his son was getting drugs, and he was getting it online and delivered right to his door. And it's very similar, a Snapchat, but he was accessing the drugs online. And I think Dr. Conrad has done some research on with the ease people can get drugs online now. It's just something that, for me as a father, terrifies me. I have 3 kids, they're 7, 9, and 11, and it terrifies me that with a click of a button, a 12-year-old could get drugs to their doorstep. There has to be you have some data that says what could we do as legislatures to help that and try and curb with the ease that these kids and adults are getting drugs online.
Is that question directed to me?
Yes, ma'am.
Yes. Yeah. So there's a lot to say here, but it's important that we recognize that young people are using digital media, and therefore digital media must be designed for young people's use, and it's not right now. So there are all kinds of privacy, features, for example, and defaults that assume that the user is an adult, when we know that a very large portion of the users of social media and other digital platforms are not, they're minors. And so we can force industry to change some of their default features so that, for example, young people are less likely to be solicited by a stranger online. And that could go a long way to protecting young people. And also, monitoring environments where young people meet online.
Thank you very much. And actually, Mr. Sword, I'd like to leave you with the last word. If there's one thing that you could ask us as legislators to do, how do you think we could help to make sure what happened to your beautiful daughter doesn't happen to anyone else? Or the best advice we could have from you, sir?
It's pretty much down to funding. Invest in the mental health of our children. It's our future that we are throwing away. Most kids now are looking at a grim future with the prices, the economy going, and they're not dumb anymore. So they're looking for escapism. So it's either some kids are turning to the drugs to forget about the problems, others are turning to video games. And neither one is mentally healthy for them. So we need to actually invest in our future and get the funding that they need so that they can get the help that they need before they become true addicts.
They need some hope.
Yes. They need a light at the end of the tunnel, and all they see is darkness.
Thank you, Mr. Sword. Mr. Steinley. Next, Ms. Kayabaga.
Do you agree that zero diversions is something that is almost impossible when we're talking about prescribed drugs or even some non-prescribed ones?
There is no such thing as zero diversion. When methadone programs first started in the early 90s, protocols were set in place to minimize that diversion, which required patients who were just recently initiated on methadone to attend the pharmacy every day and consume a witnessed dose of methadone. They weren't able to take any doses of their methadone home until they had achieved evidence of significant stability. And that was usually required over a period of 3 months. After 3 months of a patient denying use of substances substantiated by negative drugs, witnessed drug screens, where the patient would have to produce a sample of urine under witness conditions. If those samples of urine remain negative on a twice-weekly basis over a period of 3 months, then a patient would be able to take 1 dose of methadone home per week. After a month, it increased to 2. So it took 6 months, or 9 months really, to get all your take-home doses, otherwise known as carries. And even that didn't prevent diversion, but it certainly reduced it. Compare that with what is happening in safe supply clinics, particularly in London, is that you yourself could go to a clinic in London, say that you have a problem with opioids. The chances are significant that you would walk out of that doctor's office with a prescription for Dilaudid, enough to last a whole week, and you may have to witness 1 dose in front of the pharmacist, and you get the rest of your doses to take home. If it's not happening immediately, it would happen certainly after about 2 or 3 weeks that you'll be getting maybe 50, 60 tablets to take home, far more than a patient who's just had abdominal surgery would require for the management of their pain. And that is just tantamount to negligence. It's just incomprehensible. It's unconscionable that someone who is active in their disease of addiction is entrusted to take that amount of an opioid home.
Thank you. There hasn't been a lot of conversations around the socioeconomic impacts on people who become patients of drug use disorders. I'm curious to know what perhaps Mrs. Kennel, your thoughts are around some of the comments that the Conservatives have been really pushing on making treatment forced. For example, I'll give just a small example. Some communities have lower income. The median income is much lower than perhaps some of our colleagues' ridings. What are your thoughts on the socioeconomic impacts and these forced treatments? Obviously, we've seen some research that this hasn't worked. And what would happen to people who would be forced into treatments as treatments are actually sort of offered as jails? What are your thoughts on it?
Thank you very much, Mr. Kirabaga. Your question, I would say, has two parts. The first is the socioeconomic context in which people struggling with substance use disorders and mental illness face. And we know, for example, that 25 to 50% of people who are homeless or facing housing insecurity have a mental health or a substance use health concern. The correlation there is unignorable. Therefore, it requires us to be thinking cross-jurisdictionally and cross-sectorally to come up with solutions that truly address the crises and the intersectional nature of the crises that we're facing. The creation of the Canada Disability Benefit coming online this summer is an example of a type of federal intervention that can reduce the strain that poverty has on people dealing with mental health crises and substance use disorders. In regards to the issue of involuntary treatment, I would encourage the committee to focus on interventions that are squarely within the federal jurisdictional purview. We know that every province and territory in Canada has a mental health act. We know that apprehensions under those acts is rising in the face of public threat to public safety and threat to harms at the individual level. Therefore, we know that there are legislative options that are being utilized provincially and territorially. They are not perfect, and we need to acknowledge the incredible amounts of trauma and harm caused when we involuntarily detain individuals that can be long-lasting, while also prioritizing the voices of people with lived and living experience who interact with the system every single day and ensure that we are responding to their needs and their experiences with the system when developing legislative amendments to those acts or considering new legislative options.
Thank you, Ms. Cannell. Next, Mr. Moore, please, for 5 minutes. Ms. Goodrich, please, for 5 minutes.
Thank you. I'm going to start off my questions. Dr. Judson, we've had people come here from London who are prescribers of the high-potent opioids and actually say that the diversion can sometimes be seen as compassionate. What concerns do you have as someone that lives and works in London, Ontario, when it comes to diversion of these high-potent government-funded opioids?
Diversion must be minimized. That has to be a priority. I'm not opposed to pharmaceutical-grade opioids being prescribed, but is it appropriate prescribing short-acting opioids? No, I've already stated that is counterproductive. Giving take-home doses prematurely when a patient is not stable in their recovery, they've not engaged in their counseling, their psychotherapy, that is not appropriate. Someone who's actively suffering from addiction, for them to be given these short-acting opioids is just something which will deter them from engaging in lifestyle changes. And so that there must be some approach which encourages engagement with the patient and the therapist. And the purpose of the opioid replacement therapy is just to avoid the patient going into withdrawal or suffering from overwhelming cravings. Once those symptoms are eradicated, then the patient is stable. They are more likely to be able to engage in the psychotherapeutic milieu that is provided.
Thank you. To Dr. Conrad, what are your concerns when it relates to youth specifically and the very well-documented diversion that is happening of these government-funded potent opioids that are flooding the streets from coast to coast to coast?
All substances that young people use are diverted in some way. And a small portion of them would have been prescribed directly to them by a psychiatrist or a family physician. And the literature suggests that most young people are actually getting them from friends and family members. So they're not getting them directly from government. They're getting them from actors in their community, and these people could be better educated. They could be assisted, as Dr. Judson described, in having access to safer supplies of opioids for whatever reason they are being prescribed, either for pain management or for opioid substitution therapies. I do want to just add one more thing to the discussion, and that is what we need to understand is that, yes, mental health is a very big part of addiction. And what we're seeing in the safe supply and opioid substitution clinics across the country is that fewer and fewer resources are available to deliver the mental health and counseling services that Dr. Judson just described. There are fewer funds and people delivering those. And what we know of the evidence for opioid substitution therapies is that they're effective in conjunction with mental health services and counseling.
Do you believe that more needs to be done to prevent opioids and a variety of different substances from being accessed by youth?
I absolutely agree with your statement. More needs to be done on both sides, on the supply side and on the demand side amongst young people.
And so specifically on the demand side, I think that's a great space. And so has your organization been able to access federal government funding to help with funding your program of Preventure?
So, three ways. One, through research, through CIHR. CIHR has rather consistently been through the clinical trials committee supporting research on it. It's been very well reviewed and supported in that way. A lot of work, and it's a long timeline to do research in schools. The second way is through the SUOP program. I've partnered with one group in northwest of Ontario who had a SUOP grant, or was it a PHAC grant, sorry, and they did an implementation in their community of Preventure, and to great success, and it was very well received. And then the third pathway has been through provincial government. So there's a big initiative in Ontario right now through the Health Ministry in Ontario to deliver Preventure across all schools in the province. And so we have reached a point where we've trained over 1,000 community-based and school-based professionals in the delivery of the program. There are a number of challenges to this project, but the objective is to deliver this to 30,000 young people over the next 2 years.
Thank you, Ms. Goodrich. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses. Thank you, Mr. Sword, sharing your pain, your story. My heart goes to Camilla. I know I'm a mother of 2 daughters, and I know how you feel. So, but thanks all the work all the organization are doing on the ground. My question is to Dr. Concord. Dr. Concord, you talked about, the prevention professionals going to be there. We know that youth born after 2010, when social media technology screens all around them, we see more and more experts talking about overexposure of technology, as there is a clear link with the impact to mental health. To what degree do you see the impact, to suffer from addiction? What are some other factors in the environment of today's youth impact them? I know there's a question, but what can be immediately the change you are seeing?
So the situation is not as unhopeful as we all might think, in the sense that alcohol use and cocaine use amongst young people and tobacco use have consistently declined since the 70s. And so there's quite a lot that we have managed to do around protecting young people from other substances. The one substance that is showing an opposite trend are opioids. So we really need to focus on this particular behavior. Young people's opioid use is increasing despite declining rates of substance use of other forms. And it's an extremely dangerous substance for young people to be using. We need to take this very, very, very seriously. So all the trends are suggesting that there will be many more deaths by young people in this country from opioids.
Rest of the time, I want to share with Dr. Pawlowski, Mr. Chair.
Dr. Pawlowski, you get a little over a minute.
Dr. Judson, do you still work at Clinic 528? And I believe that's in London, and I believe it uses OAT therapy, opioid agonist treatment, either methadone or Suboxone. I take it from your testimony, but I wasn't quite sure. You were saying that you think the usage of that clinic and OAT has decreased because of the ready availability of safe supply and safe supply of Dilaudid in London. Do you think that's the case? And is there any evidence that that is the case? Thanks.
Yes, I do still work at Clinic 528. And as I said earlier, we originally had 1,400 patients in 2004. Now we're down to about 600 patients. We used to have 2 or 3 admissions per day. It was Monday through Saturday. That has dropped down to perhaps 1 or 2 per week at the very most. Most of the patients who are wanting sort of treatment for their opioid dependence gravitate to safe supply clinics. Why? Because fewer questions seemingly are asked, less screening, and ready availability of take-home doses before the patients are really become stabilized and got established in a comprehensive recovery program.
The only time I can table motions is during this committee time, so I hate to do it, but I have to. I'm moving a motion, Mr. Speaker, that pursuant to Standing Order 1082, given the increasing prevalence of privatized healthcare across the country and the difficulty Canadians face in getting the healthcare they need, the committee undertake a study of at least 4 meetings on protecting Canada's public healthcare system against for-profit corporations, and that the committee invite the Chief Executive Officer of for-profit healthcare providers like Loblaws Limited to testify at this committee.
Thank you very much, Chair. And once again, we see this political grandstanding of the NDP Liberal coalition that has had the opportunity for 9 years on behalf of Canadians to make the healthcare system better. And here we are talking about an absolutely incredible and important initiative. My goodness gracious, colleagues, we have a gentleman here whose daughter died from this opioid scourge, and the two of you want to go on talking about something that you had 9 years to fix. Shame on you. This is absolutely unacceptable and absolutely ridiculous. For Mr. Johns to say that he didn't have another time to bring this forward, in the vernacular, give me a break. That's absolutely untrue. This is foolishness. That we have a system falling apart, 7 million Canadians without access to primary care, that both of these individuals who bring forward a motion and an amendment to a motion had the opportunity to address over 9 years and think they have to do it now on behalf of Canadians. This is wrong. In that spirit, Chair, I would move to adjourn debate so we can get back to the important matter at hand that we have.
A motion to adjourn debate is a dilatory motion on which there is no debate. We go straight to a vote. Show of hands, please. All those in favor of adjourning.
I'd request a recorded division, Chair.
We'll have a recorded division as to whether the debate should now be adjourned. Madam Clerk.
Mr. Henley.
No.
Madame Kayabaga. Madame Brière.
No.
Mr. Polowski.
Yes.
Ms. Sidhu.
No.
Mr. Stanley.
Yes.
Mr. Ellis.
Yes.
Mrs. Goodrich.
Yes.
Mr. Moore.
Yes.
Monsieur Thériault.
Oui.
Mr. Jones. Yes, 6, nays 5, 5.
The motion is adopted. The debate on the motion is therefore adjourned. Thank you, Mr. Johns. To all of our witnesses, thank you so much for being with us. Mr. Sword, please allow me to add my condolences on the loss of your daughter, and my sincere thanks to you for your courage in coming forward in a public forum like this. It's my hope that the expertise from the other members of the panel and your courage today will all serve to ensure that fewer people have to experience what you have. Is it the will of the committee to adjourn the meeting?
Yes, sir.
We're adjourned.